Our county board proceedings will now come to order. We'll start with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Susan Locke with the invocation.
Bless us as we gather for this meeting. Guide our minds and hearts so that we will work for the good of our community, and teach us to be generous in our outlook. Amen.
Amen. Supervisor Rubel.
Thank you, Mr. Chairman. I'll move for the adoption of this evening's amended agenda.
It's been moved and seconded. All in favor signify by saying aye. Aye. Opposed? Carried. Is there anybody from the public that would like to express their opinion on anything on the agenda this evening? Now is your chance to talk. Is there anybody from the public that would like to express their opinion on anything on the agenda? One more time. Is there anybody from the public that would like to express their opinion on anything on the agenda? That portion of the meeting will be closed. Reports from committees, commissions, and boards. Supervisor Barker.
Thank you, Mr. Chairman. I received an invitation to attend the annual scholarship evening at UW-Fox, the evening of August 21st, 2014. I did attend and was recognized as a Winnebago County UW-Fox Board of Trustees member. 116 scholarships were distributed to the students seated on stage. I was pleased to see all those happy, polite students be recognized for their hard work. I will pass my program around if anyone is interested in seeing who receives scholarships. Thank you.
Thank you. Supervisor Haig.
Thank you, Mr. Chairman. If anybody drove around the highways and byways of Wisconsin this past weekend, they saw a number of signs around that reported 314 traffic fatalities in Wisconsin this year. It's interesting to know that there were 227 heroin deaths in Wisconsin in 2013. With that said, there is Saturday, September 13th in Oshkosh, Rethink Addiction Run Walk. I picked up a little brochure about this today. So if anybody's interested in participating, you'll be supporting the Rethink efforts. Winnebago County Heroin Task Force presents Saturday, September 13th. Thank you very much.
Thank you. Does there anybody else have anything to report? Okay. One of the presenters tonight couldn't make it. It was Gregory Shellbetter from Switching Power Systems. It was one of the more positive things that our Industrial Development Board did. We approved money for them to create another building for them to add more jobs to their building. We approved that at the last meeting, but he was going to explain how it went, but we'll try to get him here on one of our next meetings again. So at this time, I'd like to ask Mike Collier, the Human Resource Director, and John Stage, the Benefit Consultant. They'll come up and give us a presentation on Employee Wellness Clinic and 2015 health insurance renewal.
Good evening. I think I know most of you, but Mike Collard, the Human Resources Director, and Jan Stage is with us here today. Most of you met him last year when he came for a presentation on the health insurance renewal. He's his official title, Executive Vice President and Senior Benefits Consultant with Associated Financial Group. Close enough? Something like that. He's our benefits advisor and has been very helpful to us throughout our health insurance renewals and other things we're working on for employee benefits, which is, of course, a very large expense for the county. And that's why we're here to talk about one idea we have to try to control those costs and provide some better service to employees, which is our clinic. But just to put things into context, first of all, As you'll see when the budget documents come around, again, the health insurance line for the county, in terms of the county's total expense for providing health coverage to its employees, is in the neighborhood of $12 million. So we're not talking about peanuts. We're not talking about a minor item in the budget. We're talking about something that I certainly consider a high priority for us to always be managing as well as we can. So one of the ideas we have is an employee health clinic. This is an idea that has been percolating around the country for a number of years and really took root, I think, among larger private employers, especially in the south of the country, and has been gradually growing and spreading. It's mostly, in my experience, or to my knowledge, something that's done with private employers who start their own health clinic for their employees. Now, private employers typically have, a lot of control over their health benefits and a lot of incentive to save money on those costs, and so a lot of those types of clinics are different sorts of things where the employees really have a very strong incentive or are almost required to go to, kind of the company clinic, if you will. We're not really talking about something like that. We're talking about quite a different model. The model that we're looking at, just to get a little bit to the chase, is what I call a mid-level practitioner model. And we're talking about a health clinic that would be just for employees of the employer or employers that are setting up the clinic. Many of these types of clinics are found on the employer's location. If you have a large company, it's not unusual for, there's a clinic right there. And often that can be a real convenience to employees as well as, gets them back to work quicker, so the employers like that arrangement. One thing that I think is a creative way to set up these clinics, frankly, is to have a health clinic for employees sponsored by more than one employer jointly. In fact, I had occasion to participate in the founding and structuring of such a clinic in Sheboygan County, where Sheboygan County, we started a clinic originally just for county employees in 2008, and eventually the city of Sheboygan came in, and then the Sheboygan Area School District, which is the largest of the three employers, came in. And so that clinic is going great guns, and as a result, pretty much when I got off the bus in Oshkosh to take this job, about the first conversation I had with the city Director of Administrative Services, John Fitzpatrick, was, "Hey, Mike, we've been thinking about this clinic idea. We know you did that in Sheboygan. We want to do it here, so we're glad you're here. We can start working on that." I said, I kind of have to wait to see where we are on our health insurance before I know if that's going to work for us. But the other thing that happened is the school district superintendent, Stan Mack, happens to come from to the Oshkosh Area School District from a career for a couple of school districts, I believe, in Minnesota prior to coming to Wisconsin. And he worked with these clinics in Minnesota. So he was very positive about the idea. So frankly, right now it's the school district pushing this idea more than anyone else. They're raring to go on it because that's the direction from their chief executive. To tell you a little bit about what we're involved with. The basic idea of the clinic is we have a site near, we can't be on site because we have 3 of us, and we have 13 buildings and the school district has 20, and I don't know how many the city has. But we'll pick a reasonably central location, accessible to as many employees and family members as we can. Staff it with advanced practice nurse practitioners or physician assistants. Now, that's not necessarily something we are all familiar with in terms of a health practice, but those are the levels of practice right below a physician. So they can do, as it turns out, they have quite a bit of advanced training, beyond college, beyond what an RN receives, a number of years of training beyond that. And consequently, they're licensed to do a lot of things. I've heard it said 70 or 80% of what a family practice doctor can be done by an advanced practice nurse practitioner. And pretty much the same, I think, for a physician assistant. There are some subtle differences between the scope of practice for the two. One important thing is that they can write prescriptions. So if I have an allergy, which I do, excuse me, or asthma, which I do, I apologize if I cough too much, I can go and see a nurse practitioner and get essentially all the same treatment, write prescriptions, get my pills, get my inhalers, everything else that I might need from that nurse practitioner or physician assistant. And it might be a little easier, a little bit more convenient, and there might be some advantages to actually doing that, which we'll talk about. Another real reason or focus of these kind of clinics, though, is not just to replace what the general medical sector already provides, but to really focus much more heavily on employee wellness issues. And as I said, we have $12 million of county taxpayer money going out for employee wellness. And if you look at the statistics, we see every time that 80% of our employees account for 20% of the costs, and 20% of the employees account for 80% of the costs. And the 20% that account for most of the medical expenses are those with serious chronic conditions. If we can keep one employee a year out of that high cost category and in the medium or low cost category, that goes a long way towards lowering our total bill. So we have a generally low turnover workforce, which is great. All the more reason to invest some money into making sure they don't get into that high cost category for us. Now, what we're talking about is not a walk-in clinic, like some of the retail stores had for a while. I'm not sure if there are any still active in the Oshkosh area, where you can just walk in without an appointment, be seen immediately, pay your $50 and be done. We're not looking at quite that kind of practice. We want it appointment-based. We want to develop relationships, provide for the overall care and wellness of the patients that come. But we want to make it convenient too, so there are appointments left open during the day. Generally, we do not have, people stacked up 4 deep in the waiting room so that they can see the doctor for 3 minutes at a time, after waiting 45 minutes. It's normally a much more direct scheduled, where they schedule every 20 minutes or every 30 minutes and see 2 or 3 patients an hour, and that's all they schedule. So that's great for employees because they come in, you're generally seen almost right away if you're on time for your appointment. And it's also great because an average doctor visit, I've read these statistics, a doctor spends about 7 minutes with a patient, if you're lucky. The nurse practitioners at the clinic in Sheboygan that I'm most familiar with, it's 20 or 25 minutes per patient. So that's a big difference. They can get to know you a lot better and find out really what's wrong. In fact, I just heard a couple of success stories from the Sheboygan Clinic where a patient had just some minor chest pains and didn't think anything of it, and the nurse practitioner only found out about it because she really was being thorough and spending some time talking over the symptoms. Turns out he had 100% blockage of one artery and 90% of another, and he was really a prime case for a real severe cardiac arrest situation that was averted. And several other those kind of success stories that they have just because of the time they can take to deal with people better. Should also mention, for those fiscally minded among us, that one of those major cardiac events could cost $100,000 for the county taxpayer health fund. So, again, we're talking about general clinics. Here are some reasons the employers like them. Controls costs, and there are several ways it does that, which we'll talk about a little bit more. Improves employee health, which is a good thing. Helps us keep and retain better employees. Improves access and quality of care because they're spending more time. And also providing more expertise and assistance to the employee. Providing the steerage. Steerage is a big concept with me. If you go in and see a doctor, you may not know which doctor to see. You may just have a symptom. Who do you see? You'd be surprised how many people pick up a phone and say, "Oh, I've got an earache. I'm going to call Affinity Health or Theta Care or Aurora and find an ENT specialist." And so instead of being a $120 office visit, it's now a $300 office visit for maybe no reason. There's also steerage. If you do really need a specialist, are you going to see the right one right away? Do you need someone to help you find the right one? The clinic can really be a mechanism for us to focus on chronic conditions, disease management programs, educational materials, really a focus for our whole wellness program for employees. And a result of wellness is to reduce absenteeism, improve productivity, prevent disability claims. If we keep people out of those chronic conditions where they're always missing work, and possibly eventually becoming disabled or preventing work-related injuries, those are real benefits to the employer. Now, most of those things are things, frankly, in all honesty, we're not going to be able to measure very well. And don't expect me to come to you in a year or 2 years and tell you we avoided 3 disability claims and improved productivity, because we don't have the tools to really measure that accurately. So I'm not going to pretend to, but they're there nonetheless. There are also reasons the employees like the clinics. And I also have time to put the battery. I always forget something. Should be a power cord in there. I'm not going to let that stop me from talking while they're plugging in and resuscitating the screen. You have it in front of you, but I'll keep talking anyway. Employees, first of all, like these clinics because it's generally no cost for the employee to go. And that's the incentive. Now, our plan, frankly, isn't very well designed to steer employees toward a clinic like this, because we don't have co-pays, we don't have co-insurance for office visits typically. We have a deductible, but it's one large deductible, and essentially the first half of the deductible is paid through our health reimbursement account. So because of that, there are going to be some employees who don't use up their health reimbursement account, and so they aren't going to care if they pay anything or not, because they wouldn't anyway. And there are going to be some employees who use up their full deductible, and they won't care because they're going to use up their deductible anyway. But the employees in the middle will still be affected by that motivation, and at some future time we may be in a position to consider some changes in the plan design that will change that as well. Also, employees should be motivated by the fact that they pay 10 or 15% of our health premiums, and so anything that reduces those costs overall, part of it shows up in what the employees pay. Also, the smart employees, the well-informed employees, know that if the county starts seeing big increases in the health premiums, we're going to have to start considering changes to the health plan to save money that the employees may not like. So even the unions, do understand those arguments if they're properly made. Convenience should be a factor for employees. Now, the type of clinic we have in mind is not, I want to stress, a case where the employee has to go to the clinic and they can't go to Affinity or Aurora or Theta Care until they've been through the clinic. It's not that at all. We're relying on persuasion and incentives to get employees at the clinic. We're not telling employees they have to go there. So an employee may say, oh, I've got a great relationship with the doctor I have now, and I've got good primary care, I'm keeping track of my health risks, I know what my medical conditions are, I'm doing everything I can to keep out of that high claim category. Why should I go to the clinic? And my answer will be, you shouldn't. The clinic can't be all things to all people. But it could be another option, which can be a very attractive option for a lot of people, and a lot of people don't have a good relationship with a primary care provider already, and this will fill the gap for them. The provider has more time to talk with the patient. It's a more comfortable atmosphere, more personal, more personalized, and it provides the patient with a resource the patient can use to help navigate the healthcare maze. The world of healthcare out there is an extremely complicated one, and I don't blame anyone who has trouble trying to figure out exactly what providers they should be going to, exactly what should they be talking about, and have just a friendly face that they get to know to help them at least know what questions to ask when they do see that specialist, I think can be very beneficial. So, what I've said so far is really talking in general about these kinds of clinics and about what some other employers have done. But now I want to move from that to our current project that we have in play. And the proposal that we hope to be bringing to the board very soon is to establish a clinic jointly together with the school district, the Oshkosh Area School District, and the City of Oshkosh, as 3 employers jointly sponsoring, and I'm going to say sponsoring rather than operating, because you actually hire a company to operate the clinic for us. It's not operated directly by the employer. But a 3 employer-sponsored clinic where we're setting up the clinic, kind of describing where it's going to be, hiring the vendor, deciding what services will be provided, and so forth, jointly among the 3 of us. Now, there are several advantages to that, one of which is, frankly, most of us are politicians or work for them, and this is a great thing for the public to hear about. Shared services. A clinic jointly operated by 3 public employers can be operated much more efficiently. We can have 3 or 4 nurse practitioners or physician assistants rather than 1 or 2 if we are operating it for only our county employees. And believe me, I've done it. I've operated a clinic with just 1 nurse practitioner, and it's a very big challenge to operate it efficiently on that small a scale. Worked much better when we grew to the size by adding those other employers, where we could have 3 nurse practitioners and a couple of registered nurses and medical assistants and chiropractors. You have an economy of scale there and a real efficiency when you get to a certain size. And that's about the, I think, ideal size for a clinic of this nature. So the clinic, as we envision it, would be for employees and family members on the health plans of any of those 3 major public employers in the area right now. I know the county is the largest of the 3 geographically, and I know that partnering with the City of Oshkosh means, of course, the clinic will have to be in the Oshkosh area, or frankly in the city limits for the city to be a participant. And I know that doesn't serve everyone, but employees and dependents are scattered for all 3 of us employers. And we only can have 1 location at the present time, at least. If it goes great guns, there's always a possibility of expansion. And for those people in the northern part of the county, this doesn't leave us tied to a restrictive arrangement. In other words, if there were an opportunity to have a partnership up in the northern end of the county, Neenah, Menasha, the towns, cities, school districts up in that end, I'm open to that as a possibility as well. That hasn't taken root as of yet, but we'll see if the first one is a success. So as I said, really, as soon as I got here to Winnebago County a year and a half ago, almost, a year and several months ago, we started having some preliminary discussions about this idea. And it really sped up a little bit last fall, later in the fall. We've had probably at least a dozen meetings between me and the city and the school district people to discuss this and move it forward. We've taken a number of steps to move it along. And I know we haven't kept the board fully involved in that because it's a 3-person project, and we have to develop a lot of the idea, develop a proposal, because we have to bring the same one really to all 3 of our boards and councils for approval, which is where we are close to now. So we decided to develop this proposal administratively. We issued a request for information in December of 2013, got informal proposals, in effect, from a number of vendors, got a number of vendors saying it just wasn't right for them. They declined to bid. Looked at that information, talked over a lot of different models of possibilities, interviewed some of the finalists, I think 4 finalists in February of this year, sent out people to visit. People from all 3 of our employers visited 3 different currently operating clinics to see what different vendors looked like actually operating a clinic. So we looked at the clinic in Sheboygan, we looked at one in the West Bend School District, we looked at one up in Appleton for a private employer, all operated by basically our finalist vendors, the ones we were most interested in. And learned a lot from those visits, and were impressed by really all of their operations. We did a more formal request for proposals just to the top 2 or 3 3 vendors at that point that we were most interested in, and got final proposals from all 3 of them. And then the 3 employers got together administrative people, consultants for each of the three of us, and really selected Intera Health as the vendor nominee, if you will, to operate the clinic for us. Some of the reasons we selected Intera, next slide please. First of all, Intera is independent. You probably never heard of that company because it's a wellness company. That's all it does. It does wellness services for employers, and it does these clinics for employers, and that's pretty much its business. It's based in suburban Milwaukee, has an office now in Florida as well. They're growing, they're expanding. Happens to be, and this isn't my doing, happens to be the same vendor that operates the Sheboygan County clinic. So I don't you think I pushed it that direction because of my relationship with them, but we looked at a lot of different vendors, and the school district and the city agreed that they were the best vendor for us. But in part, it was an influence that they had that experience operating a clinic for 3 public entities in Sheboygan County. But the other thing about being independent is some of the proposals we received are from, frankly, the healthcare providers, from the Auroras or Affinities or Theta Cares of the world. In fact, those 3 all submitted proposals to us. Had a lot of concern about that because thinking about what we wanted the clinic to do, for instance, if we had Aurora operating our clinic, they wanted to send all the referrals to Aurora. Aurora isn't even in our network. So that just wasn't going to work for us at all. The provider systems make most of their money, pretty much all of their money, from what people tell me, from specialty care rather than the basic primary care services that we'd be kind of competing with. So they have an incentive to actually subsidize that primary care to get the income stream, for the secondary and tertiary care, the real expensive stuff. If it's worth a lot to them to have some influence over that referral system, I think it's worth a lot to us to prevent them from having influence. And I'd rather have those referral decisions made with advice from someone whose only incentive is to do right by the patient. And that's probably their first 3 priorities, is do right by the patient, do what's best for the patient, do what's best for the patient, and if they have a 4th priority, it's to keep the employers happy. They don't have to keep Aurora or Affinity or Theta Care happy or anyone else. They just want to do what's best, what's most cost effective, but primarily what's best for the patient. Intera, we felt as a group, was the most value providing vendor of the independents. And I'll be honest, some of the provider affiliated ones did come in cheaper, but we felt they were just being too heavily subsidized for the wrong reasons. Intera has shown great flexibility. They're good to work with, ability to adapt, ability to grow, expand the number of hours, expand the number of providers as needed, as the traffic warrants. And they have that proven track record on a very similar model, very similar project in Sheboygan County. So why do we, as Winnebago County in particular, really want to go ahead with the clinic? Well, I want to get down to the brass tacks a little bit and talk about the expense savings, the cost. First of all, substitution costs is what I call it. Well, not an original term. I think that's a good way to look at it. If I go to Affinity and say I've got allergies and I need stronger medication for it, I'll go see the doctor for 7 minutes, get a prescription for a stronger medication, and that particular office will then submit a bill to our insurance provider, currently Network Health Plan. Network then processes the bill, applies the appropriate discount rate that we've negotiated or that they've negotiated on our behalf, checks the bill against our plan design, makes sure it's payable, and eventually pays the bill. But they'll probably end up paying $120 to $150 for that if I see a general practitioner. If I see a specialist, it could be quite a bit more. The clinic, it might be $70. If I go see the nurse practitioner at the clinic, as I used to do in Sheboygan for my allergies and my asthma and things, and $70 would cover it if we can do 2 people an hour with the nurse practitioner. Might be a little less if we get better traffic through there, but we don't want to get too much traffic. So you can see right there, our health plan would save, maybe $50 to $80. Now, part of that savings might be eaten up by providing some incentive to the employee, because we're going to tell the employee, you don't have to pay anything toward your deductible to go there. If we had co-pays, we'd probably waive the co-pays. But there'd still be some definite savings left over. When I set up the clinic in Sheboygan County, I made sure that our goal was that, and these kind of costs are relatively easy to measure. I can keep track of how many office visits of which type and which code are going through the clinic for our employees and people on our health plan. I can look at our health plan statistics and know what our average cost is for those office visit types and those service types, those codes. And I can just compare one number to the other and total them up. And I did that in Sheboygan County every quarter and made sure that we were at least, at least breaking even on the cost savings I could very specifically identify, and generally coming out ahead on those costs. And that's what we project would happen here as well. So those are the costs that are fairly easy to measure. There are a lot of other costs that are not easy to measure. Steerage and utilization, as we talked about. You'd be surprised how many people go to a specialist that don't really need to be going to a specialist, and other people who might be going down to St. Luke's in Milwaukee, whereas Bellin and Green Bay might provide just as good care for that specific service and be cheaper, quite a bit cheaper. There's quite a bit of variation. It's not always easy to find out that information as a consumer of health care, so people just go where their doctor recommends. And I don't blame them at all for that. But if they're going to the clinic and the doctor isn't a doctor but a nurse practitioner working for us, they're going to keep that in mind. Improvement in employee health. Being a little bit more wellness focused, taking a little bit more time. If you just keep a few people out of that high expense category, that will show up and I'll never know who it was or how many dollars were saved. But the studies that have come out from the industry show that that's a very real savings in the long run. Statistically, there's going to be a lot of money saved there. Other than just office visits, there are going to be some other direct replacement savings. Lab work. We found in Sheboygan County that we saved more money on labs than we did on actual office visits. And we had a lot of people who might need maintenance testing done. You might have to go in every month or every 2 weeks or every week just to have a certain thing checked if you have a certain condition. Well, it can be done very easily at the clinic instead of going into a care provider. And Intera will take those blood samples. They don't do the testing themselves, but then neither does your doctor's office. They send them to a lab. And Intera has a good contract arrangement with the lab. I believe they use a lab in Fond du Lac. I don't even remember their name. But we're buying the lab at wholesale rather than paying retail. So we're getting a very big discount on that. Now, one thing we're talking about doing in this clinic that we didn't frankly do in Sheboygan County is stock some prescriptions. Frequently used prescriptions, cost-effective prescriptions. We'll have to use some judgment deciding exactly which things to stock, which things to pay for ahead of time. But keep those prescriptions on hand, and if people need a basic antibiotic or pain medication, we can't dispense the narcotics, the scheduled substances, the controlled substances, but most of the routine things we could, and basically just hand them out at the same time. A physician assistant can do that in Wisconsin now due to a change in the regulations. Again, if we're able to set that up, and we very much plan to, the prescriptions that we'd be passing out, we'd be buying at wholesale through a pharmacy vendor that Intera has lined up. 40% savings they anticipate if we could do all our drugs that way. And that's 40%. If we could do all the drugs in our health plan that way, that's, $3 million. 40% of $3 million, $1.2 million in savings there. Now, we're not going to do by any means all of the prescriptions, and not everyone's going to go to the clinic. But there's a substantial potential savings there. So Intera has done an analysis, and I don't want to present a big multi-page spreadsheet for you to show all the details, but Intera has done an analysis making some assumptions and trying to figure out what we would save. And they did include some of those wellness kind of savings for chronic conditions based on statistical standards they have and models. But they also separately broke out the what I call the hard savings, the ones you can easily identify and point your fingers to. Their projection is over 5 years, cost savings total just to the county, not to the school district or the city, they figure those separately, but just to the county of $2.8 million over that 5-year span, not per year. And that's, I think, a pretty good estimate. Now, it does make some assumptions that may not be true. For instance, it assumes that out of all the services that could be provided at the clinic, 28% of our people will go to the clinic when they have something. Now, there are some kinds of things the clinic can't do, so excluding all those, but just taking the kinds of things the clinic can do, if 28% of that work goes to the clinic, less than a third, then that's what their projection of $2.8 million is based on. Frankly, I would be surprised if we met that 28%, at least for the first year or two. I think we need some plan design changes and provide a little more incentive before we get to that level. But I think we might get to, 18 or 20%. And just my analysis, taking in Tara's math and carving out some parts I'm less confident of, I think we'd, even if I discount and ignore the wellness savings, the chronic disease savings, just look at the hard identifiable savings, I still think we only need 17% to break even. And I think we can get 17%, should be with no problem. And if we can't, we can scale back some of our costs because our contract with Intera will allow for that. So where do those savings show up? Now, we are not currently a self-funded insurance provider or insurance plan. Health plan. We are insured through Network Health. Now, I'd hoped to be able to talk to you in more detail about our health insurance renewal tonight. We are considering whether to renew with Network or to go with another vendor. Very competitive proposals from both of them. But I just got some final information I really needed to make the final decision late this afternoon, mid-afternoon perhaps. And so I'm not really prepared to make that decision, be prepared to make that decision within the next few days, though, and announce it then. But the real savings will show up this first year at least, well, or as long as we're fully insured, in the insurance company's pocket. It eventually will show up in lower premiums to us. But I'm not just suggesting that we put out $1 million of our own money in hopes of eventually saving money on premiums. For this clinic to work, the funding mechanism for at least the first year has to be provided by the insurance company. And so once we're final on our renewal proposals, I'll be able to talk to you about that because we are looking at including that funding with either of the insurers we're talking with. All right, so case study from Sheboygan County. I should mention the presentation I put together here is kind of a stripped down version of one originally developed by Associated Financial Group people, which included a lot of details from the Sheboygan Company as a model. But these are mainly things I talked about and just showed that they have had some real results in their bottom line. Sheboygan County, for instance, as the county government, has been self-funded the whole time they've operated the clinic. And over the 5-year period, 2008 through 2013, they only had one increase over 4% in the health premiums. And that's while their balance was growing from $3 million to $8 million. So they socked away $5 million in savings with only a very modest increase each year. And I do attribute that in no small part to the clinic operation. So I think we've talked about the benefits of the clinic enough. Where are we now? Why am I talking to you now as opposed to last month or next month? Well, we're at the point now where we're ready to make a decision. And the school district has been ready to make a decision. They're ready to move ahead. At least that's the sense I have. I don't know that the board has officially voted on it yet. The city is also self-funded, so they're ready to make a decision any time. And we've got to the point where we've ironed out a lot of the details, have a few more details to work out, but we're ready to start, getting down to brass tacks and some contracts with Intera and so forth. So the next step is pick the location. We're going to be leasing a location. We're looking at 2 locations. We visited both of them, got quotes on both of them, and our group, the 3-employer group, is going to meet Thursday and decide which of the 2 is preferable. One of the 2 is more in almost a downtown Oshkosh area on Ohio Street near the river. The other one is out by highways 41 and 21 interchange. I probably have to say we're leaning toward the 41 and 21 just because I think it's accessible to a wider range of people, especially for the county employees, who are probably the most broadly scattered, although all of us are. But that will be decided on Thursday. We're also developing an interagency agreement so that we have something in writing about how the clinic is going to be operated, how decisions will be made, since there are 3 groups involved. As long as people are of goodwill and working together, all those problems can be solved. In case things break down, that's why you have to have a piece of paper. But we are working on that piece of paper. The contract with Intera is going to be the crucial document. It will be a 3-year contract. Intera will actually hold the lease, so the lease agreement will actually be kind of attached to the contract with Intera as well. Since it's a 3-year deal, we'll have to come to the board. And so I'm hopeful that we'll be able to bring that to the board for a decision as soon as possible. And as soon as possible, I hope, means possibly even September regular meeting 3 weeks from today. So I hope we're in position to do that with the contracts and the other documentation. Because in order to start and open the clinic when we want to start, which, skipping ahead to the last line of the slide, January 2015. The school district wanted to start in the fall when they were originally planning this. And it takes a while to finalize the layout. The lease agreements we're talking about will involve a build-out. One of the sites is completely bare. It would have to be totally built out. That obviously takes some time. The other one, we need some remodeling that takes some time. We need to hire some staff. The nurse practitioners, the physician assistant, the medical assistants all need to be hired. So it's take at least 3 to 4 months from the time we sign a contract with Intera until the time we're actually ready to open the doors. So to open in January, we would have to have a decision by the board in September. Now, one possibility is the school district may be able to start things rolling on their own, even if our decision is in October, but we don't want to keep the school district out on their own for very long if we can help it. That essentially
How do you go about scaling back costs?
Well, most of the costs of the clinic are the salaries of the nurse practitioner, the nurses, the physician assistant. So the agreement with Intera will say we're going to pay $104 an hour of nurse practitioner time, for instance. But it's going to be a little bit flexible in how much nurse practitioner time. So we're probably going to start out with hiring 1 nurse practitioner and 1 physician assistant. But eventually, we hope to have 2 of each. But depending on how the usage goes, we don't have to hire all 4 practitioners right away. We certainly don't plan to. We're going to see how the usage goes, and then maybe add a part-time person, maybe add a full-time person, so we can kind of judge how busy things are getting, and we're only going to pay for the hours we use. So we're going to pay the rent regardless, but even the assistants, the medical assistants, the people that take the schedules and, take your height and weight, that's all per hour charge, so that's where most of the costs are. The other thing is our multi-agency agreement is going to have some mechanism that, we look at who pays what percentage of the cost. So to start out with, it turns out this, if you look at the group of the 3 employers, the school district has about half of the total employees in their health plan. And the county has about 30%, and the city has about 20%. So for every 5 school district employees, there are 3 county employees and 2 city employees. So we're going to start out paying 30%. It's going to be the deal. But it's going to see how it goes. If we're using it less than 30% of the total usage, we'll eventually pay less than 30% of the total cost. And the school district or the city would pay more, or vice versa. We could pay more and they would pay less. Because we look at that every 3-4 months and see who's using it more and make that adjustment.
Then I have one other question. Maybe it's for Mr. Stage, but employees have been asking me since this popped up on the agenda on the web that they're concerned that their benefits plan is going to go way down. They're going to lose different major concerns in their family policy and stuff. Is there anything to that?
Well, as I said, I'm not ready to announce what we're doing for sure on the health insurance for 2015, but I'm very close to being ready. And we're not anticipating what I would call major changes. And the changes that are most likely to be made are generally positive ones.
Okay.
I also think I can say on the health insurance renewal that the two bids are financially pretty close together. And in terms of the overall cost for 2015 compared to 2014, we're looking at about an 8.5% increase either way. Plus or minus, they're not exactly the same. That's not as bad as it sounds because an 8% increase was already included in the budget because we essentially, because of our very successful negotiation last year, we over budgeted in 2014 by almost 8%, between 7.5% and 8%. So it'll come out to, we think, less than a 1% total increase in the health costs, actual to budget, not budget to budget, because the budget for 2014 is too high. We'll have a lot of money go back to the general fund from that, we hope.
Supervisor Smith.
Thank you, Mr. Chairman. Mr. Collard, I'm wondering if the Intera's program will be able to utilize, we have students in the medical fields from both the tech school and the college, if they will be able to do in-services with those, which would cut costs significantly.
That's a possibility. I'm pretty sure that Intera has used interns or students for their wellness programs.
Yeah.
I'm not sure they've used them for the actual operating providers at the clinic. That's something I can ask them if they have an interest in doing.
I know sometimes just for giving, taking blood pressure, giving inoculations, things like that.
Sure.
Supervisor Finch.
Thank you, Mr. Chairman. A couple of quick questions. If it don't go according to what we as a county want, and you're going to tie us into a 3-year contract, are we actually tied for them 3 years, or is there a loophole that we can get out?
Well, we'd be able to cut back the hours to nothing, but we'd have to still pay the rent.
I understand. Also, I got enough years on here. I've seen where a lot of our employees thought they're getting something decent, and after a while they found out it wasn't as good as what they were told. Now, if they're not happy, what are we going to do about it?
Well, if the employees aren't happy, we're not forcing them to go to the clinic.
Well, what I'm afraid of is, and what I'm looking at right now is we're getting the foot in the door, and then we'll see what happens down the road. And I just want to make sure that we're going to take care of our employees, not other people. Okay?
I understand.
Thank you.
Yeah.
Supervisor Farley.
Thank you, Mr. Chair. Perhaps some more detailed questions, if I might. What is the estimated cost for Intera? You said 30%? 30% of what?
The total cost, I don't have this number in front of me, but if we were going full operation with 4 providers, I think the total for all 3 was 1.2 million.
Okay, so we'd have 30% of that.
So we'd have 30% of
estimated
that,
cost.
about 400,000. But as I said, for this to work, that really has to be picked up by the insurance company.
Now, that's per year.
Yes.
Who will be responsible for the maintenance on the building?
Intera will be responsible for utilities and maintenance subject to whatever the lease requirements are. I'm not that familiar with the details of the lease.
And you said 17% to break even, 17% of, I estimate based on the figures you furnished, about $500,000 a year in savings. Because it was estimated at $2.8 million, I believe, over 5 years.
Yeah.
So is 17% break even number of the what?
Well, the 17% was kind of a rough calculation by me based on Intera's. And so Intera was saying, yes, savings, total savings of $580,000 a year, something like that. I'm just going off my memory, so these numbers won't be exactly right. And they had that broken down, so what I considered the more hard savings was maybe $360,000 or $380,000.
Okay.
So I just figured, but our cost was only going to be, I had to figure for the cost that the, well, if I took that savings and compared it to the 23%, I tried comparing that and worked backwards from that in terms of what the cost would be. So I don't have it clearly enough in mind to walk through the calculation. And as I said, maybe I shouldn't have used that 17% number. It wasn't that precise, but I know it won't take 20% usage to at least break even.
One, to help me understand what we're saying, you said we budget about $12 million a year for healthcare costs?
Right.
Okay. So of the $12 million, we're going to take our share of the 1.2 million from the 12 million to provide the service.
Well, at least initially the insurance company will.
Okay.
Because we're really paying that 12 million to the insurance company.
So it's going to be less than 12 million to the insurance company.
No, we'll pay the same 12 million to the insurance company. The insurance company will then pay Intera some of the money that they otherwise would have paid ThedaCare and Aurora and Affinity and other providers.
I see. Where do I pick up the 500,000 a year? I guess I'm missing that. Because if it's costing the county 12 million a year,
Yeah.
I'm looking for 11,500,000. That I'm figuring that wrong, obviously.
Well, and there's some. I mean, you have to figure when I say the county share is 12 million, then you also have. It's not going to match up what's in the budget because a couple of other things. For instance, the employee share of the premium isn't even in that 12 million.
Mm-hmm.
But then we also have the health reimbursement accounts that are separately funded that we do pay. So it gets a little bit complicated, but in very rough numbers, say we pay $13 million to Network Health Plan. Okay, they are going to take our share of the $1.2 million, which would be maybe $360,000, and pay it to Intera, but then they might end up paying $800,000 less to the other providers. You know, the ThedaCare and Affinity and Aurora and whoever else.
So the savings is to them.
So the initial savings is to them.
Okay, we're going to see future savings by lower premiums. That's the focus.
If we save the insurance company money, they don't have to raise our premiums another 10% next year.
I appreciate your answers, and thank you for your presentation.
Very welcome.
Supervisor Warnke.
First of all, what kind of hours are you going to have on these clinics? Are they going to be open 7 days a week?
Now we're talking 5 days a week, but probably 7 a.m. to 6 or 7 p.m., at least some days.
Are these going to be county employees?
The people working at the clinic?
Yes.
No, the people working at the clinic will actually be Intera employees, but we and the school district and the city will have the final say on who's hired. We get a final interview to make sure that, because I know one key thing for these kind of operations is you have to have a great practitioner, who can establish that personal relationship with the patients. So we get a final interview with prospective practitioners.
Will there be a doctor overseeing this clinic?
Yes,
In other words, that they would do a referral to?
There has to be for a nurse practitioner, the answer is yes. There has to be a doctor overseeing it. For a nurse practitioner, it's just called a precepting physician, and it's basically someone who's available by phone if the nurse practitioner needs help. For a physician assistant, I think it's called something different. I think there's a little bit more involvement by the doctor required, but they don't have to be there all the time or every day or even every week, I don't believe. And whatever expense we have for the physician who's overseeing them is part of the Intera contract. We don't pay anything extra for that.
And when you're talking about the cost, are you including the cost of the equipment for this clinic?
Yes, Intera provides the equipment cost. We would have a startup fee that we'd have to pay Intera, which is really used to buy the equipment.
Okay, you are aware that that a lot of the big stores are expanding on these clinics, and I've heard recently that there's going to be a lot more of them, so your competition is going to be more too. So, and these people are open 7 days a week, and they're open, till 7 o'clock or 8 o'clock at night. But you're mostly looking at the people in the county or the city or the school system to use these.
Right, it would only be open to people on our health plan or the city's health plan or the school district's health plan. No one else could use it. And about the clinics you see in stores, those are, if I understand what you're referring to correctly, those are the walk-in clinics where, you have kind of an emergency, you've got a cut, you've got a sore throat, whatever, you walk in without an appointment. And those have not been doing well. But this would be a little bit different model because the idea would be to establish a relationship and, be your primary care provider and be available if you need to walk in, but with an appointment.
Okay, thank you.
Supervisor Haig.
Thank you, Mr. Chairman. In regard to the cost, I think that you brought up another figure here that seems somewhat undisclosed, and that has to do with the equipment in setting up this clinic. So we were talking about maybe $400,000. That sounds like it might be in the budget, it might not be in the budget. What is this fee for the upfront investment on equipment costs?
The entire contract calls for upfront cost of $65,000, and that's the total to be divided among the 3 employers. So our 30% of that would be about $20,000. And that would be the only upfront cost that we pay other than the hourly fee based on the number of providers.
Okay, so that
Plus the
sounds
rent
like
and
pretty bare
utilities.
bones. That doesn't sound like much in the way of any diagnostic equipment. We're not talking about, cone beam, x-rays here. We're not talking about anything that is diagnostic to, this is really a bare bones wellness type clinic.
Well, and the equipment, you're right, the equipment needs are not extensive. There is no x-ray type of machine. But if you go to a local general practice or family physician's office, they don't have that either. They send you maybe somewhere else in the building for it, which is actually a separate billing provider. But you're right, the x-ray equipment, for instance, is one we've talked about, and it's just too expensive. Besides which, to have an x-ray machine, you have to have a provider that's licensed to interpret x-rays, and a nurse practitioner isn't. You'd have to have a physical therapist, perhaps, or a chiropractor who would be trained in x-ray usage.
Right. Very familiar with that. Again, I just wanted to make the point about the cost. How much money has been spent on this endeavor to date already? You talk about 12 meetings with the school district, RFPs, interviews with these different providers, site selection meetings, et cetera. What are we talking has already been spent?
I don't think there's been anything spent other than employee time.
In regards to the employee time, how much money, your best educated estimate, how much money has been spent already?
In terms of my time, it's been primarily my time and also some of the benefits manager. I don't really have an estimate. I've sat down and tried to think about how many hours. It's not hundreds of hours, but it's not insignificant either.
I'm just trying to be consistent because I ask everybody who gives a presentation the same question. So if you could send me a rough estimate, I'd certainly appreciate that. This sounds like an Oshkosh-based program. What is your reaction to that statement?
Well, I think it is, and it has to be because of who our partners are. The partners available to us right now are the City of Oshkosh and the Oshkosh Area School District. So they're the ones present and interested in doing this kind of a venture with us. So this is an Oshkosh-based thing. It's going to be open to all employees of all the 3 of us. And frankly, the city doesn't have a residency requirement for most employees, nor does the school district. So they do live, in a certain geographical region. It's maybe centered on in Oshkosh. But you're right, it's not uniform throughout the county. If we have just one location, it's going to be in the city of Oshkosh because of who our partners are. As I said, certainly considered that up front, and I'm aware that that doesn't equally serve all employees. There's no way to do that with one operation. But if this clinic is successful, I think I will be, for one, very interested and maybe even affirmatively looking for opportunities or looking for partners in the north end of the county where we might be able to set up another situation there.
So with that said, have there been conversations with Superintendent Vanderkellen at Menasha, or Mary, and her last name escapes me, at Nina, or Jeff Sturgill with the town of Menasha, or Don Merkus with the city of Menasha?
No, I haven't done that yet.
You talk about 17%, and I'm really curious if that even might be an upper range based on the outpouring of disenfranchisement we had in this room when we switched insurance plans just recently. And there are a lot of people against wanting to do anything other than what they were doing. Change is hard on human emotions and the human psyche to some extent, sometimes, especially when you're talking about medical issues. So I think that even that 17%, if that's based on 900 county employees, I don't know if, I think that was Mr. Fari's question, was how many employees were you basing that on? But that may or may not be a reach. What is the potential negative economic impact to the local clinics we might see by our employees not going to a local clinic and going to this clinic?
Well, there obviously dollars that aren't spent by us are not received by the clinic, so there's going to be some impact. I can't deny it. On the other hand, I've been told by a high-ranking Aurora executive that they don't make any money at all. They lose money on primary care overall. So, and that's just an example based on my experience, because in Sheboygan County, we were very heavy into Aurora as the biggest provider. Our network in the past had been Aurora. They're the more or less dominant provider in the area. And when we started developing the clinic proposal there, it was less commonly done. It was a little bit more of a new idea. And Aurora was dead set against it. They didn't like it. They saw it as a competition. After we kicked around the idea for a year, Aurora totally changed its tune and said, we're just not very good at doing this sort of thing. It's fine with us if someone else does it, as long as the someone else is independent and not St. Nick's Hospital, who's a competitor of ours. And they ended up offering to be the to provide a supervising physician, for the nurse practitioner, free of charge, because they just wanted to, maintain that independent relationship and, keep her goodwill.
I appreciate the comments that you made in regards to the 7 minutes, and I certainly acknowledge that as truth. I mean, what we see in the medical community today is patients have less and less time, face time, with their doctors. With that said, I believe, and being involved in the dental field, I believe that dentists are now the front line of healthcare in this country. Will there be a dental facility associated with this facility?
There will not, at least for the time being. That's not included in the plan. I'm not ever shutting the door on anything that may turn into a good idea. When I've looked at or thought about dental facilities in the past, and I haven't really given it serious thought recently, I'll admit, one big drawback, but I have thought about it seriously in the past, and one big drawback is the amount of equipment and the startup cost to start a dental clinic. And I'm no expert, but I was told it really, was quite a chunk of money and turned out to be essentially cost prohibitive in terms of starting our own dental practice. I know there's a lot of money that could be saved that way as well.
Sure.
Or potentially.
No doubt it could certainly be cost prohibitive. I think the point was, if you're looking at health and wellness, that's really a place to start. People really overlook oral health care as where total health of the body starts and stops. You talked about stocking prescription drugs in this facility.
Yes.
I have a number of customers who will not stock prescription drugs because they see that as a sign that they put on their door that says, steal our prescription products here. And so I'm very curious about security efforts when it comes to stocking prescription drugs, and it may be a very good idea. On the other hand, it may be a very bad idea. In regards to the nature of the clinic, are HIPAA guidelines mandated?
Absolutely.
And I think one of the other supervisors asked a question about the hours, so there would not be immediate care offered at these clinics?
It would be an appointment-based thing. Now, if you wake up in the morning and little Johnny has a bad sore throat or a high fever, just like your doctor's office, you're going to call and say, "Can I come in this morning? I've got a urgent situation," and the clinic would set aside hours for that, planning on a certain amount of it. We couldn't guarantee you'd be seen right away, and we'd prefer that you call first, but that would certainly be open to people on a short notice basis.
The last question is this at all set up like a UW Health type clinic scenario?
Frankly, I'm not that familiar with the UW Health clinics. My guess is that they're probably a lot more comprehensive in terms of including a lot more specialty areas and different levels of practice.
Okay, I just asked that question based on that was my only choice for a health provider some years ago when I had an employer that was southern-based and didn't have a lot of facilities located in this geographical area. And what I noticed was it was really a waste of copay because they referred almost everything out to specialists. So if the UW Health type clinic scenario might be more comprehensive than what you're talking about, I would really suffer to see the need for that and for our employees. Thank you.
Supervisor Rowe.
Thank you, Mr. Chairman. Mike, thank you for all your comments tonight. I really appreciate it. My question is this. If I'm a county employee and rather than making an appointment, going to see my primary care physician, I come to this clinic, and the practitioner, you said, can write prescriptions. Is he going to have information, my medical history, from my primary care physician to know what to prescribe for me? So
yes, as long as you authorize it, and that's a key factor. And thank you for bringing that up because the electronic medical records and the exchange of that is a real need in that industry. And there are even provisions in Obamacare that it's supposed to be at a certain level by now with electronic exchanges, so that can be facilitated more easily. And surprisingly, the technology and the development under the Affordable Care Act quite hasn't caught up with the statutory language yet. But again, I can just go on my experience, and I know that the clinic in Sheboygan had a very good track record of exchanging the electronic information with the primary care doctors, the other providers that are being treated by the patients. Now, they don't automatically have access to it because you have to authorize it as the patient.
So can I conclude that any issues that come up during that visit to the clinic will be shared with my primary care physician?
Again, if you ask them to or authorize them to, they will transmit all their findings to your regular doctor.
Thank you.
Mm-hmm.
Supervisor Barker.
Thank you, Mr. Chairman. I've been listening to this all this while and thinking of when we went back and changed insurances for our people here some time ago. What I'm wondering is, have you at all spoken to the people in Menasha where we had the big hoopla because Menasha did not come in with the other cities, because we have a combination of the school district and the city employees together? Have you at all talked to them about any of this? Because they're not involved in our insurance here right now.
No, they're not, and our insurance is really just the county employees right now. And we're not talking about the public health aspect of things. But I haven't had a chance to talk with Menasha or any of the other municipalities in the north end of the county yet. Frankly, my thought is let's get this one project going, and if it's successful, we look to expand. I'm all for that.
Okay.
Supervisor Konitsky.
Thank you, Mr. Chairman. A number of my questions have been answered. But, Mr. Collard, you mentioned the school district is ready to go. They must have a site picked out for you then.
As I say, we really have two sites picked out that we're focused on, and we went and visited both of them last week. And so we've narrowed it down to two locations, and frankly, I think we're leaning toward one, the one out by the highway, but and that the school district has been a part of that just as much as I have. And so I think we're leaning toward one, but we're going to make a final decision on that on Thursday.
and the one that needs to be remodeled, how much in dollars is that going to cost, and who pays for that?
There's an estimate, I think, of $15,000 that would be included in the lease cost.
Thank you.
Supervisor Eisen.
Thank you, Mr. Chairman. Mr. Colliard, you sound very knowledgeable and experienced from your previous employment in Sheboygan and starting this clinic type there. It sounds from your demeanor that this clinic is pretty much a done deal for Oshkosh location, and of course whether or not the county goes in depends upon what the board wishes. My first impression on the presentation of the services, the bare bones services that will be offered, is that it certainly appears to be redundant to all of the services that are available through the Theta Care and through the affinity clinics. But the biggest concern, and I heard you mention that this plan is, or this clinic is only available to health plan participants. So as an employee of the county, I couldn't use their facility unless I had, county insurance. Is that correct?
Well, yes, we'd be asking the insurance company to pay for the clinic, and so they're not going to pay for someone they're not getting premiums for.
I couldn't pay the fee out of my pocket, to get that service. Okay.
Why not? We used to be able to do that through
the
the
greatest concern that I have, and in 2018, the Cadillac tax kicks in from Obamacare. And what you describe for this health clinic sounds like one of the elements of the compilation of what the Cadillac tax is based on, because it's a service being provided. Question is to present to this board before you can ask us to seriously consider it. I think you need to have a reasonable assessment of the impact of that Cadillac tax on this clinic in operation as part of the health insurance program. And I think that's important.
Good evening. Yes, we have done an analysis of the Cadillac tax each and every year for the health plan in place and projecting that forward to 2018 to see what the impact is. And with the cost, we expect the clinic, if it operates as we expect, to lower that health care cost and lower the risk of hitting the Cadillac tax in 2018. But as far as putting together specific numbers, yes, we will be doing that. We haven't done it yet, though.
Oh, the other vibe that I take from the presentation is that it sounds like, from reading the article about the clinic in the Northwestern, it sounds like the school district insures with UMR, which is through the Counties Association, which is United Healthcare, and it sounds like they were in competition at the last renewal, and but for the underbid of the existing provider network, they would have or may have been successful. It does appear from the published information in the newspaper that UMR is picking up about 80% of the startup cost for the school district, putting that into the pot to get that clinic going in respect to their contribution. I think that if this board is going to make a fair deliberation, I think we would have to have our insurance carrier put to bed, know which direction we're going, and then perhaps at a subsequent meeting take on the implications of establishing a clinic. The clinic is something that Mr. Stage had presented the concept to us in previous years as a trend within the industry. So it's not completely new when I saw that on the agenda. But I do think that there are some very technical financial implications, and I would like to see, I think that it would be important for Associated to keep, to maintain a report to the board on where we are with that Cadillac tax, because it's only in 3 more model years that the Cadillac tax is going to pick up and be enforced, because you've got 2015, 2016, and 2017 renewals, and 15 is already here. That's just around the corner. And so I do appreciate the hard work that you've done and the experience that you've shared with us. It's certainly convincing on its face, but there are several elements that need to be put on the table and to make a good decision among 36 supervisors.
Jan, you want to step up there? Seeing you're on the agenda, you can join in also and do your part. Supervisor Skellinger.
Thank you, Mr. Chairman. The gentleman next to me kind of alluded to to how do we change people's habits of consuming health care, and I'm maybe the perfect person to talk to this, as in the last 2 months I finally got rid of my pediatrician and have a real primary care doctor for adults now. But that's a habit thing. It's really hard to break these healthcare habits. What tactics do you plan to use to get Winnebago County employees to use this new clinic?
Well, it's going to have to be a variety of things, and I do want to say that, in terms of the resistance to change and the overall atmosphere and feeling of employees, what I should have said before. I mean, when we started this clinic in Sheboygan in 2008, this was long pre-Act 10. Frankly, we had a fairly rough union environment in terms of negotiations and resistance to change at the bargaining table with the unions. And nevertheless, even in that environment, the clinic was very much seen as a positive step by employees. The employees, even employees that didn't go to the clinic, said to me, I appreciate that the county is doing this because they're finally, for a change, doing something for employees instead of just taking something away from us. So I think the impact on employees should be a very positive one in terms of the fact that we are giving them an additional option that really can benefit them if it's appropriate for their use. Now, in terms of how to actually get them in, I think the best tool is word of mouth every time. And so what we found most successful was just, getting employees to meet the nurse practitioner, and get to know her a little bit, or just be exposed to her and say, oh, this is someone I could go see. This is someone I could trust. This is someone who, A, is very easy to talk to, and B, seems to really know what she's doing. And so it's that kind of thing that's going to make the sale, is going to really compel people to come in. An advertising blitz isn't going to do anything compared to that. And then once 10 people go in and see that nurse practitioner and say, this is great, they're going to tell, their coworkers, and word is going to get around, and you can't pay for that kind of publicity. So it's really crucial to have the right person. And then I think especially the initial weeks and months, schedule may not be too full. We take the practitioners and we send them out to employee meetings, put them in places where employees can see what they look like and how they act.
Okay. So I know I like the nurse practitioner model. I mean, I think this is one that works to reduce costs and increase care. One of the questions I have, though, I guess, is how will someone at this clinic coordinate advanced care, like with, let's say, a gastroenterologist or something like that, between multiple different healthcare systems? I mean, is there case studies about how this has come into play? Because you alluded to how hard it is to navigate the healthcare system when you're in a single stream, but it seems like now we're almost in a a whirlybird here.
Yeah. Well, and again, I'm not an expert on the upper levels of the healthcare industry. I mean, I know something of the finances of it, and from the employer end, certainly. But I would think that if someone's having a complicated, difficult, expensive procedure, there are going to be physicians involved, and one of the physicians should be probably the overall coordinator of the patient's care at that point.
So in this setting, the nurse practitioner that you go to establish your care with is not going to be the person who facilitates, for example, like if you need to go have a CAT scan, they're not going to be the one that facilitates the continual treatment of that issue.
Well, I think if you just need a CAT scan, the nurse practitioner can arrange for that. But if you need, an operation to have a brain tumor removed, I think the nurse practitioner is going to bow out after perhaps she provides you with some help in finding the correct surgeon or the correct physician to coordinate that procedure.
But is this health center still going to be their point of entry? I mean, essentially, is it going to be able to serve as in the same capacity that a primary care doctor would?
Let me try that, because if someone's already seeing a doctor and under care, those people are being taken care of and they're being referred as you're talking to. What we're looking to get at are those people who don't have primary care available to them and haven't used it for whatever reason. And so we're hoping to have them look to the clinic for that direction. Now, when it comes to referring, what are we looking for the clinic to do? Most people today, if they don't have primary care, are referring themselves. Statistics will show that if someone has a condition and they self-refer, half of them are going to the wrong physician. And so we're hoping instead they come to the clinic and they can at least direct them to the right kind of specialist. We're not necessarily looking for them to refer to a specific provider, but at least area of specialty.
Right. And so once they go to that specialist and that specialist does their tests, does the diagnostics, gives them their results, who is that specialist turning them back over to? Are they turning them back to this clinic, or is this clinic not equipped for that?
It's a great question. And a lot of the questions that have been asked so far, clinics for employers do that. But that's not where we're starting. And that's not where we're going to be at when we begin. And so I would think that in that situation that you're describing, that the specialist would refer them to a primary care, not at the clinic. That wouldn't be something that the clinic would undertake.
So they would effectively have 3 appointments with 3 different providers.
At that point, once they're referred out of the clinic, I would not see that happening. I wouldn't see them coming back to the clinic is what I'm saying for that condition.
Do you anticipate employees establishing a primary care at this facility, though?
Here's what we're trying to do. Is that Mike mentioned earlier that, yes, acute care will be available. What I mean by acute care is if someone has a sore throat, has an earache, that type of thing, and they want to be seen in the same day, yes, those services will be available. But really the goal is, and this goes back to a discussion I've had with all of you in the past, we're focusing on those people with chronic disease. And if you remember the discussion, people who have chronic disease are most at risk of having large claims. So if we can get them into the clinic diagnosed and, most importantly, get them on meds and have them be compliant with those meds. Statistic from Mayo Clinic says 50% of people who are prescribed maintenance drugs don't take them as they should. So if we can increase that, lower the risk for the individual and the health plan, you're going to save a lot of money doing that. So that's the focus of the plan to begin with. Now, having studied this, there are clinics that go so far as to control everything for the employer clinic, and that means every specialist visit. Okay, we're not looking to do that right now. I've looked at the dentist thing too, and I agree with Mike. The upstart cost is way beyond where we're at, and it's probably years out if ever considered. We're going to start small and gravitate to larger expenses, larger areas as it can. But to begin with, it's going to be acute care, but mainly focusing on the chronic disease.
Do we have any case studies for a public clinic like this that has pharmaceuticals?
Do we have them on hand? No. Are there? Yes.
Do you know of them offhand, or I mean?
Specific studies? No, I don't.
Okay. Is that something that we could be provided? Because I think probably a lot of us share that concern about having.
What we do have available from Intera, who's doing the work on that and doing a feasibility study for the county to see if it's worth our while. They've taken the specific claims data from the county and given us a report that shows what the potential savings is. So it's specific to the county.
Great.
And I think that would be the best place and the best report to see.
Great. Will this facility serve as an occupational health site for county employees?
Probably not, at least at first. I think there are going to be some occupational health issues coming in the door, but we're not going to require all pre-employment physicals go there, at least right away. That's something we could definitely expand to.
Okay. And my last question is, do we currently see a need for our county employees to consume more health care? I mean, are they not going to the doctor enough, or is it, or is it more to your point of managing those chronic things? I mean, is that? I mean, how? Let me ask this. I rephrase it. How big of a concern is it that we have county employees who are not utilizing their health insurance?
Well, I'd have to subdivide it a little bit more closely to give a meaningful answer, I think. I do think, beyond any doubt, that there's a group of employees that are not using their health care enough. And I no doubt there's a group that's using their health care too much. And I think the clinic can actually help improve both situations. For instance, and to get back to a question you asked earlier about primary care. I haven't seen a doctor myself since 2007 because we started that clinic in 2008. I used it as my primary care. I know I'm not the only one. In fact, I would say that we were surprised at the proportion of employees that did use it as their primary care. And we looked at those, and those aren't people who had been going to see their favorite doctor for 20 years who they knew very well. These are people who really didn't have a primary care relationship. And all the studies show that if you have people without that primary care relationship, they're maybe not going to go seek that health care until it's too late and they're in that high-risk category. So you save a lot of money by providing those people that primary care. And so I think, we had a lot of, our biggest trouble scheduling at the Sheboygan County Clinic was for annual physicals. Because it took that takes a lot more time, and they didn't have enough time in the schedule, and sometimes we had people complaining it took too long. It took 2 or 3 weeks to schedule a physical. We're supposed to be able to walk in the next day at the clinic. We expanded some of those hours, but what it really told us was that people are really using this as primary care, and it's because otherwise they weren't getting it at all. On the other hand, the people getting too much care, some of those people are doing a lot of self-referrals and not really exercising the most informed choices about who they're going to see, and there we can hopefully help that out a little bit too.
Thank you very much.
Mm-hmm.
Supervisor Fari.
I wanted to add just to answer your question about are there people within your health plan who are underserved or aren't receiving the care they should? And the answer is clearly yes. And that's a population thing, and it's mainly males over 50 who aren't going to the doctor unless they're close to dying or diseased. And I'm part of that group. And yes, so if we can use this to get those people in to find out if they have a condition and treat it and be better off, I think it'll be a win-win.
Thank you, Mr. Chairman. A follow-up question about Mike, and let me say it might put you on the spot a little bit. It is a hypothetical question. As I'm sitting here thinking, and based on your comments, you did say that we're going to be reviewing our current health policy that we provide to the employees. Yet for 2015, that'll be coming up?
Right.
Okay. hypothetically, if this was approved and established, then would the initiative be either financially or by other health agreements that the board would approve to direct employees to this facility then? I mean, are we going to start integrating it where they're going to say, well, if you go to this facility, you're going to save $20 or whatever? Is that going to be a focus? And I kind of think you perhaps alluded a little bit to that.
Well, and I'm not trying to be coy, or hide anything. For 2015, for next year, no, nothing like that. We're going to have the same plan. When I talk about possible changes, frankly, depending on which vendor we pick, one vendor has a broader network than the other.
Mm-hmm.
Okay, so the network will look a little bit different and a little broader if we go with the group health trust, and that's a positive thing for employees. That's really all we're looking at for next year. We're not anticipating any other plan design changes for 2015. Now, if you ask me in future years, do I want to consider some plan design changes? Yeah, I think they have to be on the table. If you look at our plan design, it doesn't provide a uniform incentive for employees to be good consumers of their own health care. Mm-hmm. And that's really what you want to have. You know, we've got, you know, if you're single, if you have a single plan, the first $750 is all on the county, the second $750 is all on you, and after that, it's all on the county again. You know, so I think most plans that have that kind of arrangement have it because there's a carryover or something else that provides that incentive to employees, but we don't have that. And that would be expensive just to add, so I don't think we can just add that without also making some other changes. Another way to go, and I'm not saying we're going to do this, I'm saying another way, common way these kind of plans are structured is instead of having that big deductible and no copay, you have a much smaller deductible and then, you know, you pay 10% up to a certain amount. Mm-hmm. Something like that. I think depending on what our costs look like, we might have to look at some of those models. But again, it's not because we want to, you know, make it harder on employees. It's because they might save us, you know, help us control costs a little bit better while just providing a positive incentive for employees on our health plan. Generally, that would also work better with the clinic. In other words, the same, if there's a 10% copay up to a certain amount, we'd waive that if they go to the clinic. But, you know, and that would be a little bit more incentive. But
yes. So what I understand you, then what we're saying is that perhaps eventually this facility would kind of play into or be part of a change down the road. This would facilitate that change, perhaps.
Or it would really be the change would facilitate usage at the clinic.
Okay. All right.
Be the other way.
Very good. Thank you.
Mm-hmm.
Supervisor Olson.
Thank you, Mr. Chairman. I don't want to keep this going all night, but I do have just a couple of clarification questions, if you don't mind. If I'm a county employee right now, I'm covered under the network plan. Okay. Currently, how much premium and what is the deductible for someone, a county employee?
Again, I'm not going to remember the exact numbers because I just don't remember numbers that well. I remember estimates. I'm a good estimator.
Yeah, estimate.
Single or family?
Family.
$1,587 a month.
That's the
total premium.
Premium, okay.
Yeah, now that doesn't include the health reimbursement accounts,
right.
But it includes all we pay network.
Okay.
Yeah.
If somebody chooses to go to this clinic, what is their out-of-pocket cost?
Nothing.
Nothing. If they go to their primary care provider, what is their out-of-pocket cost?
Depends where they are in their deductible and their reimbursement account. So it could be nothing, it could be the whole amount, it could be somewhere in between.
Would it behoove the employee to go to the clinic then, because they're not paying for out-of-pocket?
Well, right, absolutely. And as I say, there are some employees who don't care because they have very low expense, so they're going to be fully covered by the reimbursement account either way. There's going to be another group that's burned through their whole deductible either way, but that whole big group in the middle should be influenced by
I'm
that.
one of those with a chronic disease, and I tell you, if I could go to a clinic that when I have to pay out of pocket, I would do it in a heartbeat.
Yeah.
You know, The other thing I wanted to talk about quickly is the Cadillac tax that my colleague brought up. It's my understanding that the Cadillac plan is a 40% excise tax on plans with premiums exceeding $10,200. Are you ever going to reach that threshold?
That's the analysis that we'll be doing.
Oh, okay.
And what we do is look at current costs, and that includes the health reimbursement account, and then trend it forward and to see where we end up in 2018. With the plan, that there is a risk using trend figures of getting there with the current plan design by 2018.
Okay, thank you. The other question then is, going back to another colleague, about the specialist. If I came in and I was told I needed a specialist, could I then go back to my primary care provider and have them do the referral?
Well, that's an option available to you, but it isn't required. In other words, you can skip the primary doctor level and just go straight from the nurse practitioner.
Fortunately,
to the
I'm stuck in
specialist.
a plan where I have to use a specialist in my network, so I don't have a choice, but that's the way it is in the rural world. Okay, thank you.
Supervisor Eisen.
Thank you, Mr. Chairman. Mr. Carroll, it sounds like that you would be asking the board to consider a 3-year contract on a bare bones clinic arrangement partnership. And I would hope that when you present this and ask us to consider this, that we have the startup costs identified, and then also the annual costs identified for this arrangement. And the other question I would inquire, if you could try and think back, or to your best contact with the Sheboygan County program. I see from the Sheboygan County website that they currently they have in their clinic 3 nurse practitioners, 2 licensed practical nurses, and 2 chiropractors. That's a pretty heavy staff. What kind of a premium would that generate for the cost of a clinic?
When you say what kind of premium, Sheboygan County and the other entities in that clinic are all self-funded. So they aren't actually paying money to an insurance company. They're using their own self-insured fund to pay the claims on one hand, or to pay the clinic on the other. And at least while I was there, I mean, this is something I did on a quarterly basis. Every 3 months I would look at how many visits there were, what the average cost would have been if they had gone somewhere else, and what the actual cost was at the clinic, and it always came out ahead.
Is that going to be in the choices that we'll be looking at when we entertain the renewal with the present provider in a fully insured plan?
Oh, yes.
And consider our prior carrier, or partial prior carrier, with a fully with a self-funded?
Well, let me put it this way. I mean, self-funding is always an option we can look at and think about, and we are going to always be evaluating whether we should go self-funded as opposed to fully insured. We're not looking at that for 2015 because we still have good insured options for 2015. But I do want to assure you and the rest of the board that I would not ask the board to vote on a contract with Intera without having first nailed down the health insurance company funding for it. And so I don't have that quite nailed down yet, although I'm very close. And I regret that I don't have it nailed down, because I had hoped to be able to tell you exactly what it was going to be at this meeting, so that we wouldn't have to talk theoretically like this.
Well, I have a lot of confidence in your expertise and your knowledge and your desire to provide the best for Winnebago County. Your stewardship is appreciated.
Supervisor Keel.
Just one more thing. So I'm understanding you right, because we started a while ago. So basically the 2 big ways that this is a positive, if it works, is not only getting the chronic patients the steady care they need, as well as spending more efficiently or intelligently on the things that a lot of us use, just so I'm hearing, am I saying that correctly? Okay. Pretty basic. I know that's really basic, but that's how I learned, so thanks. Okay. They
Okay,
nodded.
thank you. That's it. Well, we'll keep forging on. At this time, I'd like Peter Mall to come forward. He's going to give us an update on what he has to do on the reconstruct taxiway B.
Good evening. In your package, you should have received an insert that talks about our capital project that we proposed for 2015, which is the reconstruction of taxiway B, or Bravo, as we call it in the aviation industry. A little background: this runway, or this taxiway rather, parallels the east-west runway 927. It was originally constructed, we estimate, back in the 1960s, so it is an asphalt surface. It does have significant cracking, both longitudinal and transverse cracking on the taxiway, which becomes a hazard for taxiing aircraft and minorly in snowplowing operations. Every 3 to 4 years, the Wisconsin Bureau of Aeronautics contracts with an engineering firm to do studies of all the pavements at publicly funded airports in Wisconsin. In 2012 was our last pavement condition report, and during that time they noticed that portions of this taxiway are in the failure state, and some are also in not quite failure, but it needs significant reconstruction. So that's why we worked with the FAA and State Bureau of Aeronautics to present this project to you. What we're proposing to do then is to reconstruct the entire taxiway. I think there was a map included with your packet. The taxiway would be constructed with concrete, full length. There's a little bump out toward the end of runway 9 that you'll see. That was done years ago to include a localizer antenna for an instrument landing system. That system is no longer needed, nor is it desired under FAA standards. So the whole taxiway would then be straightened out. We would also change some of the taxiway cutoffs so that we don't have direct access to the runway to prevent runway incursions. You'll also notice too that there's a note. You may not be able to read it on your copy, but we would also, as part of the project, replace all the taxiway edge lights with LED lights. Currently, all the taxiway lights are incandescent bulbs. We go through probably 400 to 500 bulbs a year because of that, because they're on constantly at night. And then also during winter snow removal operations, sometimes vibrations from snow hitting these lights will also knock out the filament and knock out the light entirely. So LED lighting would save us a significant amount of money in the long run in terms of energy costs. And we would also relamp all of the runway lights on runway 927 as part of this project too. So a good portion of this project would incorporate the replacement of those lights. In terms of cost for this project, looking at a total of $5.5 million. Now, the FAA, under the AIP program, the Airport Improvement Program that they have, would pay for 90% of the project, or $4.95 million. The question comes up every time: where does that money come from? It doesn't come from your property taxes, doesn't come from your income taxes. That money from the FAA comes from ticket taxes that you pay when you fly the airlines. It comes from fuel taxes and fuel fees if you buy aviation fuel for your aircraft. So if, in a sense, then the funds are self-generated by the aviation industry. 5% of the cost of the project, or $275,000, would be paid by the State Bureau of Aeronautics. Again, funds that are generated from the aviation industry in Wisconsin. And then the county's portion would be 5% also. So in other words, $275,000. So in a sense, for the entire project, we're putting down a nickel and getting a dollar's worth of work out of that. The Project, again, we're coming to the board, for your approval at the future meeting to acquire these funds. The FAA is looking for concurrence from this board first before they would give us the funds. As with all FAA projects, we don't know for certain whether we will get the funds, but they are putting money aside for that with a number of other projects around the state and around the country for that. If funding is not available for 2015, we would not do the project, obviously, when we wait till the FAA funding does come through. So, with that, any other questions about the project? In particular, I'll try to answer those best I can.
Supervisor Eisen.
I don't have a question in respect to this particular project. It's very clear, and I appreciate your presentation, Mr. Mull. The question I would have is, whatever happened with the committee study on the control tower after EAA?
Oh, the funding for operation of the control tower?
Okay. This board refused to air condition that control tower.
Okay. No.
For 2 years in succession. What came of the survey after EAA? Could you share that with us?
We did have one minor glitch with the air conditioning system during AirVenture this year. Nothing that was catastrophic, however. So we can't. Right now, we don't have money in the budget.
That's not on the agenda tonight.
Oh, I'm sorry. Sorry.
Supervisor Roll.
Thank you, Mr. Chairman. Peter, if you had to state what the major benefit of this project is, what would you say?
The major benefit is safety. First of all, because of the condition of the taxiway, reconstructing it is going to prevent future breakup of the asphalt, which could lead to ingestion of particles, chunks of asphalt into aircraft engines or damaged propellers on aircraft as they're going along. Safety from another standpoint, though, too, is that with a direct parallel access to the runway rather than a curved is better for taxiing aircraft. It's a shorter distance for the taxiing aircraft in a straight line. It also gives us on the end of the runway, on runway 9, right now the offset from the end taxiway going into the runway is about 300 feet, in which larger corporate jets have to back taxi and turn around and use the runway. This way, they're at the end of the runway, they'll be able to use it full length.
So that's just a convenience?
And I wouldn't call it a convenience because pilots tend to want to use every inch of the runway they can. So.
Well, I mean, it's a convenience to have them not to have to turn around.
Oh, yes, in that regard, yes. It's less time spent on the runway for an aircraft, especially when you're using have a higher operation period, especially during EA. You want to get aircraft in the air as soon as possible.
How many seconds would you think it would take to turn a plane around?
Depending on the size of the aircraft, it could be anywhere from 10 to 30 seconds.
Thank you.
Welcome.
Supervisor Widener.
Thank you, Mr. Chairman. Just following up on Supervisor Rowe's question, assuming that the feds do not provide the money for us, you said we put it off for a year, and yet you said it's a safety issue. Would we have to shut down the runway? What will we do if we couldn't get the money for a couple of years?
Well, we wouldn't shut down the runway. I mean, the runway is going to stay the same. The taxiway is going to stay the same. It's just that the condition of the pavement is going to deteriorate a little faster over the year.
And so when will we be at a position where we wouldn't be able to use it anymore?
Potentially in 2017, the report indicated a greater number of areas that have potentially failed asphalt. So we would have to do, if we didn't have any funding, we'd have to repair those sections, but not the entire taxiway. We just have to do it in sections and then at a future date, reconstruct the whole taxiway.
Okay, so basically you would do patching until we could get the money. Is that correct?
Correct.
Okay, thank you.
Okay, thank you.
Thank you.
Supervisor Robel.
Thank you, Mr. Chairman. I'll move that we adjourn until Tuesday, September 23rd at 6 p.m. for our regular county board meeting.
We are adjourned.